So today's presentation is about the epithelium. Is it a friend or a foe? So just an overview, the corneal and conjunctival epithelium are a continuous layer, and they provide the biodefense system to the anterior surface of the eye, and it gives a physiological protective layer to any external stimuli. However, the epithelium can be your enemy in some situations. Today I'll be discussing three entities which the epithelium does not behave normally, and the latest modalities for diagnosis and management. First, we'll start with the recurrent corneal erosion. In this situation, the epithelium does not stick. It grows normally, however, it does not stick. It's defined as recurrent detachment of the epithelium from the basal membrane. It's a spectrum from mild discomfort, from microcysts, to more severe extensive erosions taking days to heal. Symptoms include pain, which can be very severe, awakening the patient from sleep, photophobia, epiphora, erythema, and decrease in vision. The incidence is 1 in 150 traumatic corneal abrasions. Can be also seen with basal membrane dystrophies, like map-dot fingerprint dystrophy. If associated with the dystrophy, 87% in the inferior half of the cornea. The etiology is extensive. The most common is either traumatic or basal membrane dystrophy. In cases of the trauma, usually it's a very common trigger. Basal membrane is destroyed or damaged. It can be either isolated or secondary to any underlying disease, like a dystrophy. A more extensive classification is either primary or secondary. Primary including all the epithelial, stromal, and endothelial dystrophies. The most common is the map-dot fingerprint dystrophy. And the secondary could be either secondary to trauma, degeneration, eyelid pathologies, post-infection, post-refractive surgery, or in some systemic diseases like diabetes. The mechanism in recurrent corneal erosions is usually structural changes that weaken the epithelial cell adherence, in which there's basal membrane deficit, absence or abnormality in the hemidesmosomes, and loss of the anchoring fibrils. Therefore, it leads to abnormal production of the basal membrane. It also showed that there is a link with an increase in the matrix metalloproteinases 2 and 9, which are usually found in the basal epithelial layer and play an important role in anchoring systems of the cell and the basal membrane. This is important to note because of the role of the doxycycline corticosteroids and autologous serum in the treatment of recurrent corneal erosions. So treatment can be classified as topical or surgical. In cases of topical, lubrication is the mainstay of treatment. Contact lenses with prophylactic antibiotic also plays a role. However, there's always risk of infection. Hyperosmotic agents, corticosteroids, and autologous serum drops. Autologous serum drops contain fibronectin and prealbumin. In fibronectin, it improves the migration and anchoring of epithelial cells, and prealbumin increases the stability of the lacrimal film. This can be used alone as solo therapy, or it can be adjuvant to PTK. In terms of surgical modalities, it can be either a partial keratectomy, anterior stromal puncture, either manually or by laser, PTK, and alcohol delamination. In partial keratectomy, it is removal of the corneal epithelium down to the level of the Bowman's membrane. It can be done either manually with forceps or just a sponge, with application of a bandage contact lens, or it can be done with a diamond burr polish. The role of the diamond burr is just to smoothen the surface. This decreases the recurrence rate as compared to just doing it without the diamond burr. And this modality is actually inexpensive and can be done in the clinic. The anterior stromal puncture, ideally, it is done using a 25 gauge needle with about 0.1 millimeter spaced punctures, 5 to 10% depth in the cornea. And the goal is to induce a fibrotic reaction, increasing the adherence between the epithelium and the underlying basal membrane. After that, it's recommended to apply a bandage contact lens And the success rate is variable between studies, but it's about 60% success rate. The advantage is that it can be done in the clinic, and there's no refractive changes, and because there's no effect on the vision. However, the disadvantage is it cannot be done in the visual axis in the center of the cornea because it might affect the vision, and there is a risk of perforation. I came across these other modalities of anterior stromal puncture using the ND-YAG laser, which is usually aimed at the basal membrane. It works the same as the needle, however, this uses YAG instead of the needle. So the risk of perforation here is less. It's usually more efficient with trauma cases than the basement membrane dystrophy, and the success rate is variable between 55 to 85%. The third modality is PTK, phototherapeutic keratectomy, with ablation depth of 5 to 9 microns of the Bowman's layer. It has a higher success rate with traumatic cases than in the dystrophy, which is about, depending on the study, 46% to 96%. The recurrence more often occurs about 5 months, with an average of 5 months after the treatment. The effect of the PTK is that it induces a reactive fibrosis that adheres to the epithelium, which increases the amount of hemidesmosomes, therefore preventing the recurrent corneal erosions. However, the complications in PTK include a transitional haze and a hyperopic shift. And the instrument is more expensive compared to other modalities. The final modality is the alcohol delamination, which was introduced by Dr. Dua. The idea behind alcohol delamination is that it leaves a smoother surface for the epithelium to grow as compared to PTK and punctures with a diamond burr, which leaves a rough surface for the normal healing. The hypothesis is that damage to the Bowman's layer induces accumulation of keratocytes and cellular debris, which diminishes the cellular adhesions. The method is 20% alcohol for about 40 seconds, and then removal of the epithelium. So the key to prevention of future erosion is lubrication, at least every night for the following 3 to 6 months after treatment. The second entity is epithelial ingrowth. The frequency of epithelial ingrowth is variable depending on the study, but it's about 3.5%, and usually we see it more with retreatments and enhancements. The risk factors for epithelial ingrowths can be either modifiable or non-modifiable. The non-modifiable risk factors include increased age, type 1 diabetes, the presence of basement membrane dystrophy, and the type of correction. It's seen more with hyperopia more than myopia. This is because of the more peripheral treatments and hyperopic treatments compared to myopes. And also the flap lift for the treatment. This, we cannot modify it. However, the modifiable risk factors include the use of microkeratomes more than femtoseconds, and it's more with enhancement versus primary treatment. For retreatments, lifting the flap with the forceps increases the risk of epithelial ingrowth compared to just cleaving it with a spatula before. Also, the side cut of the flap edge, usually when it's done manually using a microkeratome, it is a 70-degree side cut, as opposed to with femtoseconds, we use a more vertical and smoother cut, which is about 115 degrees. This decreases the risk of epithelial ingrowths. Also, any corneal epithelial injury or LASIK flap complications, like dislocation, thin flaps, free caps, or epithelial tags, all increase the risk of epithelial ingrowths. So regarding the classification, it's usually classified to 4 grades. These are photos that basically show the different degrees of epithelial ingrowths. In grade 1, which is the most common pattern, there's a faint white border inside the flap. It's usually non-progressive and no treatment is needed, but the patient needs to be followed up. In grade 2, it's usually more aggressive than grade 1, and it tends to be usually progressive, but treatment is needed, but not as urgently. Patient can be followed up and treated in 2 to 3 weeks. Type 3 is usually a more aggressive pattern. Urgent treatment is required because this can progress to the visual axis or can cause melting. Grade 4 is the most worst grade, in which there is corneal melting, and it usually involves the visual axis, and it's very difficult to treat. So the mainstay of treatment for epithelial ingrowth is initial observation, since management of this complication is very difficult, and usually it has a 10% incidence of recurrence. However, the surgical indications include progressive epithelial ingrowths into the visual axis, or which affect visual acuity, or non-progressive, but the cyst formation and the elevation causes irregularity on topography and cause astigmatism, and also flap melting. So this is a case of Dr. Sami. So this patient came to KKish with post-LASIK treatments elsewhere, and he had a myopic regression. So this patient underwent LASIK re-enhancement using a microkeraton. This was actually done in, I think, 2005 or 2006. So it was before the availability of the femtosecond hair. And the LASIK enhancement was done using a microkeraton to correct about a -6.5. The surgery was uneventful. The patient had a 20/25 vision post-operatively, and he was very happy. The treatment was regular, the flap was lifted, and he did have a small epithelial defect post-operatively, which healed in 4 days. The patient came 4 weeks after treatment, and he had this clinical picture. Initially, he was observed, but then it started progressing and getting closer to the visual axis. So we elected to treat this patient, and we took him to the OR. The flap was elevated, and there was irrigation of the flap bed with alcohol and debridement using Lexol. And then the flap was sutured, and this was the appearance only 2 months after the treatment, with complete resolution of the epithelial ingrowth. I don't know if the photo is actually clear or not, but the patient had 20/25 vision. So for the treatment of epithelial ingrowths, generally it's mechanical debridement. The flap is lifted and the epithelial ingrowth is removed from the stromal bed and the stromal side of the flap. The suggested technique is debridement of the epithelium from the bed of the inner surface of the flap. If the ingrowth is present early, less than 4 weeks, usually a Wexel would remove any residual epithelial cells. However, if it has been there for a very long time, slight pressure with a blade may be needed to remove any residual epithelial cells. The flap can then be replaced, and the interface should be generously irrigated with sterile distilled water to remove any additional epithelial cells. It's a good idea to put on a bandage contact lens afterwards. However, some recent studies showed that bandage contact lens can cause a recurrence. The flap can be managed with sutures, which decreases the chance of recurrence, or fibrin glue. Other modalities of treatment for epithelial ingrowths include PTK, which is about 5 to 10 microns of the 5 to 10 microns of PTK, or Nd:YAG laser, or amniotic membrane. So this is a modified surgical technique that utilizes intraoperative OCT in the removal of post-LASIK epithelial ingrowths with irrigation of alcohol and mitomycin. The idea behind this is we get direct visualization of the epithelial cells in the nest, and we can make sure intraoperatively that we remove any residual epithelial cells. So prevention is best. So the way to prevent epithelial ingrowths is to have larger LASIK flaps, to use femtosecond flaps, more in hyperopic treatments, and PRK touch-ups in cases of enhancement instead of redoing the LASIK. And to treat any progressing ingrowths earlier, as advanced cases are more difficult to treat and higher risk of recurrence. So ingrowth and downgrowth both mean epithelialization of the anterior segments and form either sheath-likes or cysts inside the eye. These terms are used interchangeably. However, epithelial ingrowths are usually seen when epithelial cells migrate under a stromal flap after LASIK, whereas epithelial downgrowths usually occur after trauma or intraocular surgery. This is when epithelial cells migrate inside the eye. It's usually very difficult to treat and has a high risk of complications like corneal decompensation, intractable glaucoma, and even phthisis. So epithelial downgrowth is one of the worst outcomes when it grows inside the eye. Intraocular epithelium does not develop de novo, so it must gain entry through any opening, usually resulting from inadequate delayed wound closure or actual seeding of the epithelial cells during trauma or surgery. Several decades ago, epithelial downgrowths accounted for about 27% of enucleations. The most common causes were trauma or complicated cataract surgeries. It was actually rarely seen after penetrating keratoplasty or glaucoma surgeries. Nowadays, we do see epithelial downgrowths in corneal transplants, especially those that use venting procedures like DEMIC or LASIK. It can also be seen with sutured IOLs and other glaucoma surgeries. The mechanism in epithelial downgrowth is usually delayed closure of corneal or scleral wounds, or the epithelium is seated directly into the eye during surgery using instruments or through and through sutures, or during trauma. It can happen either soon after the trauma or the surgery, or it can be delayed up to 10 years after. The average is usually 5 months after trauma or surgery. So what does it look like? It can either present as a whitish grayish membrane on the endothelium, as in this photo, or it can show as an epithelial cyst, as in this photo. So early in the disease, it's usually difficult to recognize. Patients can only present with corneal edema, or if there's presence of a fistula, it can present as hypotony, or it can be a sudden spike in IOP if this fistula closes, which can lead to chronic angle closure glaucoma. So to diagnose it, usually by retroillumination, the red reflex will look irregular, corrugated look, as in this photo, as compared to the smooth appearance in the normal cornea. It also affects the corneal endothelial cells. So by tomography, we would have a thickened cornea, and we would have an abnormal specular microscopy when we do endothelial cell counts. By corneal OCT, it will show a hyperreflective line where the cells migrated through. This can be helpful in diagnosis and also during follow-up after treatment to see if there's any residual cells. So the initial management in epithelial downgrowth is observation. However, it's very difficult to treat. There are many modalities for treatment. First one could be argon laser on the lesion. This could be either therapeutic, this can be diagnostic and therapeutic. Once we hit the lesion with argon laser, the epithelial downgrowth would look like a fluffy whitening of the epithelium, whereas a normal iris would just turn brown. We can also use intracameral 5-FU, but the goal of the treatment is to either identify and remove all invading epithelial cells with complete resection of the involved structures in the eye, and then adjuvant cryotherapy to destroy any residual cells. It can also, we can also do corneal transplantation in the form of DASIK or PKP. So for argon laser, this is the typical setting for epithelial downgrowths. The side effects of argon laser is angle closure glaucoma, formation of synechia, hypotony, correctopia secondary to any iris involvement, and decrease in vision due to corneal decompensation, and also tractional RD and phthisis bulbi in end stages. So 5-FU is also used in the treatment of epithelial downgrowth. 5-FU is an anti-metabolite that inhibits cell proliferation. Theoretically, because the epithelial cells in the AC of the eyes with epithelial downgrowths are proliferating, the drugs should be ideal and selective pharmacological antagonists. There are different methods of treatment, dosing for the 5-FU. Most studies recommend 500 micrograms in 0.1 ml injection inside the AC. Then the patient would be in a face-down position for about 30 minutes. It's variable 30 minutes up to 1 hour. Initially, should be 2 weeks apart, and the dose should be repeated either monthly, depending on the patient's response. Usually, it only works in mild, early diseases. So prevention is the best. Delayed wound closure and wound leak, prolonged wound leak is actually increases the chances of epithelial downgrowths. and early treatment is best if it's progressing. So take-home messages. Abnormalities in the epithelium include epithelium that can grow but does not stick like in recurrent corneal erosions. There's no perfect treatment. There are multiple options. We can mix and tailor depending on the case. And epithelium that can grow in unpointed places like ingrowths and downgrowths. Ingrowths which are seen usually in LASIK, post-LASIK procedures. There's always a place for suturing. If we put a suture at the end, or if we're suspecting that there's an increased risk of epithelial ingrowths, a suture would actually prevent it. And we always treat early before the flap melts. In cases of downgrowths, if the case is complicated or we're suspecting that there's a seeding of epithelial cells, good suturing of the wounds would prevent it. And it can lead to very severe complications like angle closure or otitis bulbi. Thank you.
Thank you, Dr. Thank you, Dr. AlBathi. Anyone have questions?
Thank you, Dr. AlBathi. That was really an excellent revision of the epithelial behavior in abnormal conditions. I have a couple of comments about it. You know, we always think that epithelium is a very benign, cells. However, and there are certain also pathologies where if any other structures in the eye starts to behave like epithelium, like in eye syndrome, the whole description will be almost similar to what you have described in the last pathology. So the epithelial downgrowth is going to behave like more or less similar to the eye syndrome. However, I still have some recommendation in just not calling it epithelial downgrowth. I prefer to call it like an epithelioma. The reason behind, because it's really behaved like a tumor, and really you can't get rid from it easily, and it's not even a benign one. It's like more or less the heavy condition and malignant one in behavior. The other thing also, I wish that you also mentioned, it was the epithelial replications in OSSN. So the corneal also involvements in OSSN also is a unique condition. There are some genes that also control the epithelial replications, and when that gene is suppressed, then the corneal OSSN will continue for life. You won't be able really also to get rid from it. So also indicating that the epithelium of the cornea is totally different than the conjunctiva, and it's not an easy also to how to control. Otherwise, really, thank you for all the comprehensive cover for this topic. Yeah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. AlBathi, for this very nice talk. It's some comments. First one is the Dua's comment about not using, for example, the eczema, or just sticking to only using the alcohol delamination of the epithelial basement membrane, thinking that the eczema will cause accumulation of inflammatory cells, and this will prevent the epithelial cells adhesion. But I think this does not make sense, because we use the eczema in PRK and we aggressively ablate the cornea, and yet the epithelium sticks. And actually, if we want to do retreatment after PRK, you find that it's very difficult to remove the epithelium. So the fact that the eczema causes the cells to accumulate, I don't think that this argument is valid. The other thing, the use of mitomycin to prevent epithelial cells from multiplication is also not valid, because we use mitomycin nearly in most of our PRKs, and people use it in glaucoma. But in PRK, we use it after removal of the epithelium, and yet the epithelium heals in just a few days. The epithelial cells are not affected by mitomycin in terms of their, the way they slide and then multiply. So using mitomycin inside the eye to kill the epithelial, whatever you call it, ingrowth or downgrowth, I think it will kill other structures inside the eye and it will leave the epithelial cells. The last point is I think that some people tend to use fancy techniques to treat trivial things. One example is using YAG to treat recurrent corneal erosions. I would rather use the 30 gauge needle. I think it's similar to that is people using the laser to occlude the puncti. I think it's uncontrollable when you want to use the YAG, and how many shots will you apply to the cornea? It's very difficult to gauge the level at which you are going to shoot the YAG. Thank you very much.
Thank you very much, Dr. Lohain, for informative presentation. Actually, the best treatment for such condition, which nowadays very rare, alhamdulillah, is to prevent it. In the past, there were many things which lead to the formation of either endothelial growth or the complication, which is known in ophthalmology. Nowadays, improvement of the OR circumstances, surgical technique, everything. So rarely nowadays you find this complication. As I mentioned from the beginning, the best thing is to prevent rather than to treat. And the one which is most of the time, even in the LASIK, when you have LASIK flap, just to take care of the flap and the orientation of the flap and the position of the flap and clearing of the under flap. This is the most important and which was the most common thing. The endothelial growth, if you have the vitreous in the wound, or you have irregularity of suturing, and this was happening with the ACC. Nowadays with the phaco, it's much less, unless you have trauma. So this is common with the trauma. So thank you very much for the presentation, which is important, and thanks God, it is very rare nowadays.
Any questions and comments?
Thank you, Dr. Lohain, very comprehensive. A question about 5FU. Have you encountered any use of 5FU in post-LASIK downgrowth, either topical or irrigation? Was it used? Was it studied?
Actually, no, but I did find it in the studies. There were two studies documenting the use of 5FU to treat the epithelial downgrowths. And actually, the results are not very strong. The number of patients used were not a lot, and the recurrence rate was high.
Okay.
So I don't think it was a very wise modality of choice.
Okay.
Thank you, Dr. Lohain, for this great presentation. I just want to ask about the NDN laser use. Do we use it here in Cambridge?
Actually, no. During my fellowship, and now I haven't seen anybody doing it, but it was documented in the studies.
Thank you.
It's been proposed by Alu and his group in Spain in 2009. And they published a couple of case reports, and then after that, I haven't seen any publications since ever using that technique. Yeah, because most of the cornea surgeons prefer the mechanical ones.
And their recurrence rate is
And
just as high as the
exactly.
mechanical.
Yeah, and too much inflammation created with using
One thing regarding cells, epithelial cells getting inside the eye. You know, the cells, it depends on the ability of the cells to multiply. Now, few cells from for example, for those who had exhausted their multiplication potential, even normal cells, in the epithelium, the cells with the maximum multiplication potential are at the limbus. And then you find the transient amplifying cells, and then towards the centered cells lose their ability to multiply a lot. So if some of those cells get inside the eye without continuation with the limbus, they will die off. They will not make any trouble inside the eye. And we do surgeries, you know, during surgery one cannot guarantee that few cells will not get into the eye. but there is no continuation with the limbus. The danger is when there is a continuous leak, for example, when the stem cells of the limbus or the area of the transient amplifying cells are in continuous in continuity with the inside of the eye. Then even the cells that die off, as they do in the ocular surface, the cells of the limbus and next to it will continue supplying cells inside the eye.
I actually have a question regarding epithelial cysts. I haven't seen any case yet, but maybe people with experience know. Do you inject alcohol or mitomycin or 5-FU inside the cyst before surgical excision of it, or do you just excise it without any injection? Because I've seen different methods and different recommendations.
I think these are rare cases, and you may spend a lifetime of practice and you hardly face any. But traumatic ones are very challenging, okay, because they are usually from the stroma, not the epithelium. Sometimes there are epithelial cells from the iris pigment epithelium itself, and those cells are different. Those are not cells coming from outside of the eye, but from inside of the eye. Pigmented cells, sometimes you find them floating. If they are small, they can be removed. Any cyst inside the eye can be removed, potentially removed, unless it is really stuck to the stroma. Then you have to violate the cyst, and sometimes it tends to recur again. Epithelial cysts going inside the eye to make a ball, it goes again back to the same principle, whether the cells are capable of multiplying or not. So I don't think that I have enough experience in dealing with such a thing, but from the cases that I saw in the past, if the cyst is large and touch the endothelium and damage the iris, then surgery really can, even if you debulk the cyst and remove the content, it tends to recur. The damage to the endothelium sometimes is irreversible, and sometimes the inflammation that happens can continue to cause further damage to the eye.
Regarding the intraocular cysts, usually I always compare it with delivering a baby. If you deliver it in a nice way, you will avoid complication and all the delivery complication. If you just try to will it, it will rupture and it will spread more and it will be a serious complication in future. So usually I have many cases, and alhamdulillah I don't have any recurrence. This is mainly in the past. And usually I debulk the cyst, aspirate it, then with the same needle I don't remove it, inject alcohol, then leave it for a while, then debulk it again, and usually it is encapsulated. So just peel it gently, even when you use Kilman or tooth forceps, and it will come easily, and you will take it as a whole cyst. So this depends on how you manage this. Try not to open, because this definitely will spread the cells, and it will be in the angle everywhere, and you will have serious complication in future.
Any other comments?
Any other questions? Okay, so we can conclude the session. Thank you so much, Dr. AlBathi.
Thank you.